Hi, everybody. We are going to go ahead and get things started. I am really excited and honored to have Dr. Kate Hutcheson with us this afternoon to present Integrating Digest into Clinical Practice. A couple of housekeeping items before we get started. This webinar is eligible for zero point 0.1 ASHA CEUs or 1 PDH. If you're interested in obtaining ASHA CEUs for attending this presentation, we ask that you stay for the entire duration of the session and that you fill out a brief survey at the conclusion of the course. The survey will be posted in the chat and it will also be sent out to you via email from Zoom. It will be open for 7 days, at which time we will close the survey and submit to ASHA for CEUs. If you have any questions as we go along, feel free to pop them in the chat or the Q&A box, and Dr. Hutcheson will answer questions at the end of the presentation. And finally, if you would like a certificate of completion for attending this session, send us an email at tims-univ@tims.com. And with that, I'm going to hand over the floor to Dr. Hutcheson.
Well, thank you so much, Brooke, for the invitation and for inviting me to join the Timms University. I always hear great things about it. So let me go ahead and get my slides shared and pulled up. Are you seeing the full screen of the slides?
Yes.
Awesome. So my goal today is to really steer the conversation about digest in a place that's pretty practical to thinking about how to use it in a clinical setting, both in cancer but also outside of the cancer arena. And I'd like to start with my disclosures. Grateful for salary support from MD Anderson, and also specifically for research funding from MD Anderson. Our institutional research grant program is the group that originally funded the development of Digest. And we currently have funding from the National Cancer Institute for work that is really focused on helping us to support clinical implementation of Digest, particularly in cancer care. So just a little bit of background about me. I've spent my entire career practicing as a speech pathologist at MD Anderson Cancer Center in Houston, Texas. And we are a national comprehensive cancer center in the Texas Medical Center. We are regularly ranked the top cancer center in America, and we're ranked that way this year. And specifically, my home department is the Department of Head and Neck Surgery. And you can see a little bit about our department here. We're a large faculty of about 45, mostly surgeons, but proudly boast two faculty speech pathologists who do clinical care as well as research, sort of practice-oriented research in speech pathology. And in this role, I also have the opportunity to serve as the section chief over our speech and audiology programs at the hospital. And this includes 20 cancer specialized speech pathologists. And I'll take the opportunity to encourage anyone who's interested in this type of practice environment to consider applying. We do have one opening on our speech pathology team right now, and there's a QR code for that on your slide. So a shameless plug there. But we'll get into the course objectives at this point and broken it down into 4 goals. My goal is to give us at least 10 to 15 minutes for Q&A. So we'll try to cover this in about the next 45 minutes, which includes a description of Digest as an evidence-based practice tool in dysphagia, how to get started using Digest and the tools that are available to help clinicians successfully adopt Digest, thinking about how Digest integrates with other dysphagia practice tools, and describing ways that we can use Digest in our clinical decision making. So let's start with the tool itself. Digest as a tool is simply the flow sheet or the decision tree that you see on the left-hand side of this slide. And this decision tree was used to create a reproducible criteria for grading the severity of the pharyngeal stage of dysphagia on video fluoroscopy or modified barium swallow studies initially. The Digest grade is based on patterns of bolus clearance over multiple bolus trials in the study. So it's not a single bolus that we're grading, but the entire exam. And ultimately, it is based on swallowing safety as marked by penetration and aspiration events, as well as swallowing efficiency as marked by pharyngeal residue. Because we developed Digest initially for cancer, the 5-point severity staging that we use is benchmarked to the common way that cancer clinicians or oncologists grade the toxicities or severities of cancer-related side effects. And I'll give you a little bit more information on this in a couple of slides. But in this framework called CTCAE, grade 1 would reflect mild side effects, grade 2 moderate, grade 3 severe, and grade 4 it's described as life-threatening, or maybe more appropriately in the dysphagia setting, profound. The original tool was developed in 2016. We refined the grading in 2021, which was just a small change in the loop in the decision tree for grading swallowing severity. Swallowing safety impairment. And then the final sort of overview step was to adapt Digest in 2021 for fees. And for those who do both fluoro and fees, it's important to note that the safety grading for Digest fees is identical to the safety grading in Digest version 2 for video fluoroscopy. But we had to adapt the efficiency because you can't look at residue in the same way that we describe for Digest for video fluoroscopy. You can't look at residue that same way on fees. I thought I'd take just a very brief detour to share how we actually how I actually came to develop Digest, which was at the incessant urging of my first chairman. So this is Dr. Randy Weber, who was an amazing chair, really great at mentoring folks and developing his faculty. And every year in my annual review, in my early years on faculty, he would say, like, Kate, when are you going to develop a tool for grading swallow studies? And I would say, Randy, there's like a million of them already out there, and I don't want to create anything new. And he finally said something that sort of stuck with me. And he said, yeah, but oncologists don't know how to interpret the results that you guys put into your swallow studies or into your research. And so that got me thinking about how oncologists think about the side effects of cancer. And in cancer, side effects are referred to as toxicity. And there's a very established framework for grading cancer toxicity, which is called the CTCAE, or the Common Terminology Criteria for Adverse Events. And this is a document that has been maintained for many years by the National Cancer Institute. It has, I believe, at this point, over 800 different potential toxicity items. So things like mucositis or nausea all would have a CTCAE grading. And it essentially assigns a 5-point ordinal grade and criteria for the different severity of the side effect from the clinician's point of view. So all of the toxicity items in the CTCAE are clinician graded. And I got to thinking that this might be a really good benchmark for sharing the results of the modified barium swallow study, which is clinician graded, in a way or a terminology that cancer specialists could understand, which would be a CTCAE compatible result. And so here what you see is the universal criteria that the CTCAE uses to define the severity of cancer toxicities, where grade 1 is mild. It's defined by often asymptomatic or mild symptoms, or a scenario where the toxicity is observed only on clinical or diagnostic observations, or a scenario where the toxicity is mild enough that intervention may not be indicated. They define grade 2 as moderate, which is a toxicity for which minimal, local, or non-invasive intervention is indicated, or a scenario where it is limiting higher level activities of daily living. Grade 3, they define as severe or medically significant, but not immediately life-threatening. And I think this is a really great way to think about the severe classification on Digest. So medically significant, but not immediately life-threatening. Or it could be a scenario where the side effect, the toxicity, is severe enough to cause hospitalization or prolong a hospitalization, or is disabling, or is limiting sort of lower level activities of daily living, like bathing, sort of the fundamentals, bathing, dressing, feeding, etc. And then grade 4 is a life-threatening toxicity, or a scenario where urgent intervention is indicated. Like in a modified barium swallow study, you're doing a swallow study and you're saying to yourself, this patient needs to go to the emergency center to immediately have a feeding tube placed because they're not really safe to leave the institution swallowing like this for a few more days. Um, and then grade 5, which isn't relevant to the results of a modified barium swallow study, was death related to the adverse event. And so we used this framework as the basis for the content validation or the benchmarking of the MBS results when developing Digest. And it's kind of hard because this is very vague, but when you think about what we mean by a grade 1 Digest result, it means toxicity or swallowing problems in this general lane. And I think that that's something that's sometimes missed when folks initially look at Digest and where it is now. So I wanted to share that when we're thinking about the clinical use of this tool. What Digest did was then map what we see on the modified barium swallow study to putting the results in those general lanes. And as many who are familiar with the instrument might know already, this here is the Digest safety grade. So the Digest safety grade starts by scoring penetration aspiration scale scores for each bolus in your protocol, and then identifying the maximum or worst degree of penetration and aspiration scale scores that were observed over the entire study. As you move over, modifiers are used for branching logic in the decision tree that account for the frequency and the amount with which those higher grade penetration and aspiration scale scores were observed, ultimately deriving a safety grade here. Those grades align to that toxicity framework you just saw. So grade 1 safety would be a mild safety impairment, whereas grade 4 safety would be a profound or life-threatening safety impairment. Likewise, the efficiency grade for Digest starts by observing the amount of residue for each bolus trial in your protocol, and then identifying the maximum percentage of residue that was observed over the course of the study. In the right-hand side of the decision tree, you can see that the logic branches in the scenarios where higher grade residue was observed. So more than 50% or more of the bolus retained in the pharynx after swallowing. When you observed 50% or more bolus residue, we want to know the type of boluses that that's happening on to ultimately derive the efficiency grade. And again, that is benchmarked to the CTCAE framework, where grade 2, for instance, would indicate moderate grade inefficiency, and grade 3 would indicate severe inefficiency. And then the final Digest grade sort of crosswalks the safety impairment and the efficiency impairment to give an overall impression of the severity of the pharyngeal dysphagia. So for any instrument or tool that we use, it's super important to understand what it is and what it is not. And just to recap, Digest is a CTCAE compatible method used to grade the severity of the pharyngeal phase of swallowing impairment from a modified barium swallow study. It was also adapted for FEES. It was developed for cancer initially, and specifically head and neck cancers. It's based on patterns of bolus clearance throughout the pharynx. It was designed for real-time clinical use, but also for use in dysphagia research as an outcome measure. But it is not a lot of things. Digest does not measure timing. It does not measure physiology of swallow. It does not measure the oral preparatory or oral phases of swallow. And it does not measure compensation. All of these other important factors of your swallowing performance need to be observed and measured with other tools when conducting your modified barium swallow study. So we've been on the journey with Digest for about 10 years now. So after developing the tool in 2016, we immediately clinically implemented the instrument at MD Anderson, and we've been using it institution-wide since that time. But we also had a focused goal on broader clinical implementation of Digest, how to facilitate that outside of our walls here at MD Anderson and outside of cancer care in dysphagia. And so we've sort of incrementally and more slowly than I would have liked, but incrementally created sort of resources and infrastructure to try to support that. The first step was developing a training program. So we initially launched a virtual training program in 2020. We were actually scheduled to have an in-person training and then had to rapidly sort of migrate that to a virtual environment during COVID. And then adapted the tool for use with fees in 2021, and then refined and relaunched our virtual training program, integrating fees into it in 2022. And it's now a fully asynchronous training that's self-paced for the individual. Since that time, we've really been trying to look at our clinical data, our clinical research data, to bolster the evidence base supporting clinical implementation of Digest as a tool. So we've had the opportunity to evaluate the feasibility of using Digest in a busy dysphagia practice. Here at MD Anderson, we do about 2,000 modified barium swallow studies a year, and we've been able to identify that in close to 14,000 swallow studies that were conducted in the initial years after we developed Digest, more than 99% of the time, if you had an MBS at MD Anderson, you had a Digest grade in your chart unless you'd had a total laryngectomy. So it was pretty feasible even in a pretty busy and diverse cancer practice. We've also looked at the question of clinical utility and specifically identified that the Digest grades that we identify in the medical record of our patients systematically relate to the recommendations that we make from our modified barium swallow studies in an expected way, meaning, for instance, that the higher the Digest grade, the more likely you are to be recommended for a compensatory strategy and specifically more complex compensatory strategies. Likewise, Digest has been found to relate in a systematic fashion to the diet recommendations that we make from our swallow studies. And this all suggests the concept of the utility of the measure toward its intended goal. And finally, we've looked at the question of reliability and training, and we found that while a number of clinicians are reliable at using Digest just by picking up the flow sheet and putting it into practice, that there is a value in increasing clinicians' both accuracy and confidence in using Digest by participating in training. And you can see here the QR code for our Digest training program, which is available only in a virtual format right now, but fully asynchronous, so you can do it on your own time. So in the last few years, we've had the good fortune to be funded by the National Cancer Institute to conduct studies helping us to facilitate broader clinical implementation of Digest in cancer care. One of the first goals of these studies were really to what they call scale up the tool, which is to try to address gaps in the evidence that prevent clinicians from feeling confident in using the tool in their own practice environment. And so there were two primary questions that we tried to address in this work. And the first is probably the number one question that I get when I'm presenting about Digest, which is, can I use Digest in this clinical population? And I'll tell you that the practical clinician in me will always just say, it depends. And what I mean by that is Digest grades the swallow based on the observation of penetration aspiration and pharyngeal residue. And so if you have a patient population or even a specific patient where their swallowing impairment has manifested in penetration aspiration and pharyngeal residue, and that's a lot of our patients, then it's probably likely that Digest will generate a valid grade of the dysphagia for that individual. If, however, you're working with a clinical population where a lot of the impairments in the mouth, maybe there's a lot of oral perseveration or a lot of oral inefficiency, but once that bolus gets back to the pharynx, they swallow without pharyngeal residue penetration or aspiration, then Digest hasn't captured the impairment for that individual patient, and it's not the appropriate, or at least it shouldn't be the exclusive tool used to summarize that swallowing impairment. The other question we get a lot is whether you can use Digest in a particular protocol or practice pattern that you use within your organization. And because of the way that we developed it to be a fairly pragmatic and scalable tool, I used to always say, well, we think so, but we didn't really have the data to show that. What we've been able to do in the last few years through this Digest implementation study is to sort of put some data behind these points. So these are busy slides, but I'll just share that at this point, we now have Digest validated in all cancers, so not just head and neck cancers, but broadly across all oncology. We have Digest validated in neurogenic dysphasias, specifically stroke and ALS. We have it validated in inpatient or hospitalized populations, and this is specifically acute care for oncology, as well as non-cancer related surgical populations such as ACDF. And there are a host of other validations that are currently underway. We've also been able to identify, again, busy slide, but to show all of the work that we're doing to try to understand how we perform our modified barium swallow studies and how flexible we can be and still use Digest appropriately. We've been able to identify that Digest is stable when the modified barium swallow study is recorded under 30 frames per second. Whether or not you standardly implement a sequential swallow task in your bolus protocol, and whether or not you standardly implement thick liquids in your bolus protocol. So that's a little bit about the tool and the current evidence base for Digest. Let's move on to how you get started with using Digest and the tools that can support your use. So here you see the Digest readiness checklist, and this is work that's also derived from our implementation study that's ongoing. If we have clinicians on the call who participated in our surveys or our focus groups, thank you, because this is sort of one, not sort of, this is the end result of one of those projects, which used survey data and interviews of clinicians to come up with a list of sort of prerequisites that would indicate better readiness to both start using Digest and master using Digest. So clinicians told us that to start using Digest, there needed to be a perceived need for a standardized tool that could measure dysphagia considering both safety and efficiency. The clinician needed to have a general awareness of Digest and its purpose and be comfortable implementing a bolus protocol that included multiple bolus trials. They also needed to be comfortable continuing a swallow study after aspiration was detected using their clinical judgment on whether it was appropriate for an individual patient's risk. They needed to follow more globally a standardized protocol for their MBSs, record MBSs, and use the penetration aspiration scale score. And that way that a readiness checklist would be used is if you're interested in starting using Digest, the more of these that you say yes to, the easier it's probably going to be to get started. And the more of these that are absent in your practice might help point you in the direction of things that you could do to get ready to use Digest more easily. The last set of 3 items were items that our clinicians suggested reflected readiness to really master Digest and become sort of a super user. And the first one was time available to dedicate to Digest training. The second was working in an environment where you and your team use common protocols to conduct swallow studies. And then the third was working in an environment where you and your team uphold competency standards for clinicians conducting modified barium swallow studies. So that's more about the practice environment. What I'd like to move on to now is how you actually conduct your study when using Digest and how you get started in that space. As I mentioned previously, Digest is a pattern-based measure, meaning we're not grading an individual swallow. Well, we are, but that's not the Digest grade. The Digest grade is based on the pattern of performance of all the swallows on your bolus protocol. And so for that reason, this is an instrument that's very particularly vulnerable to conducting a modified barium swallow study in at least somewhat of a standardized fashion. So the two factors that contribute to a valid digest grade are how you perform the swallow study and how you interpret it. The first step to performing the swallow study in a way that makes digest feasible is using a standardized bolus protocol. We do not have a digest protocol. Our goal has always been that digest would be scalable to work under different standardized protocols, and that's part of what we're testing in our implementation study right now. But what I share on this slide is the bolus protocol that we use at MD Anderson. So this is the bolus protocol that was used in our validation studies and is still used in our clinical practice. You will see that that bolus protocol includes multiple trials of IDSI level 0, so thin liquid barium. It includes an IDSI 4, a pudding level, and an IDSI 7, a solid level. If thickened liquids are given in the test, whether or not they're in your standard bolus protocol, they are scored. And any other bolus given is not scored in the current paradigm. For those that are astute, you can see that there are sort of gaps. Like we don't have in the digest methodology what you do with an IDSI level 5 or 6 in the current framework. The I have often been asked, like, what's the minimum bolus set that we think is required to use digest reliably? And we are testing that in our current research, but I propose, this is not tested, that it probably is somewhere around 4 to 5 trials of thin liquids, at least one pudding and one cracker. And we're testing that sort of minimum bolus set in current projects. A couple other tips are to limit queuing. So the goal is to rate uncompensated swallows. So the minute you see barium hit the vocal cords, please don't say clear your throat and swallow, because then we haven't seen the actual level of impairment. The goal is to observe how the patient would be swallowing if they weren't sitting in radiology, what would be happening with the safety and the efficiency of their clearance. We also encourage you to record all the natural clearing swallows. This is particularly important in clinical populations where delayed airway entry from residue is common. And an important note is that you're not expected to exactly follow the bolus protocol in every single patient in order to use digest. It was developed in a way that we assumed that bolus trials would be skipped, particularly in higher grade impairment. But it is designed so that you follow the bolus protocol in all other scenarios as best you are able. So avoiding deviation from the protocol unless there's truly severe or profound impairment or very poor tolerance of the examination. Then the interpretation simply includes scoring the penetration aspiration scale on each of the bolus trials in your protocol and rating residue on each of the bolus trials in your protocol, and then applying those observations to the flow sheet. So here you can see in a little bit more detail the steps to assign a safety grade. So you start by scoring penetration aspiration scale scores for each bolus in the trial. You do not rate the penetration aspiration scale score on a bolus trial after a strategy has been applied. So if you observe silent aspiration, then you tell them to cough and they clear it, you would still score that an 8. You then you then collapse the maximum penetration aspiration scale score from all the bolus trials into sort of 2 score ranges and select that maximum range. And if the maximum PAS score is 3 or higher, then you apply modifiers to describe how frequently the higher grade penetration and aspiration scale scores occurred and in what amount. And then the digest flow chart is used to assign the safety grade using all of that information. Likewise, for efficiency grading, you start with an estimation of pharyngeal residue on each bolus trial in the protocol, and this is made at the point that the patient, at the end of the initial swallow of that bolus. You don't have to be exactly right on residue, you just have to get in the right range. So residue is then put into ranges of under 10%, 10 to 49%, 50 to 90%, or over 90%. If the maximum residue observed was greater than was 50% or more, then you select a modifier demonstrating which bolus types that occurred on. And ultimately, you would use the flow sheet to take those observations and assign an efficiency grade. So how to digest the analog way is to use paper forms, which I still use in my clinic. I had a fluoro clinic this morning. And here you can see just one example of a paper form that you might use to track, I should say, the penetration aspiration scale scores and the residue ratings for each of the bolus trials in your protocol. So you might see this as your result where, the first thin liquid trial had a PAS score of 1 and residue under 10%. Whereas the, first cracker trial had a PAS score of 1 with residue in the 50 to 90% range. I've taken these results here and put them into this easier to see table next to the flow chart to show that we would then observe the worst of impairment on PAS scores, which I've blocked in blue, the worst of impairment in residue, use that information then to crosswalk the flow chart. So for this patient, the maximum PAS score is 3 to 4. 3s and 4s occurred chronically, which is defined as 50% or more of the thin liquid trials on this bolus protocol. So that is a safety grade of 1, S1, reflecting mild safety impairment. For this same study, the maximum residue was in the 50 to 90% range. It occurred only on the cracker bolus, which gives us a moderate inefficiency, grade 2 inefficiency. E2 result. Then we crosswalk S1. E2 is an overall digest grade of 2, moderate pharyngeal dysphagia. Now, for those who are using TIMS, which I would assume is many folks on the TIMS University webinars, there are tools within the TIMS MVP software that I'm going to briefly review that do also help you to use digest. One of those is the scorecard. And you can think of that as the non-paper way of tracking your exam result. And then the other one is their measurement tool, which can help you with feeling more confident in residue estimation in some scenarios. So let's look at the scorecard. Tim Lazan isn't able to be with us today, but he was nice enough to put together these slides for us for another project, and I'm sharing them with you that show how the scorecard works to help you track your digest grade. For many, you are familiar of the TIMS scorecard feature. You would start or open that by selecting the scoring icon at the top of your MVP site icon. And then there are a number of different outcome measures that have a scorecard available. Digest is one of many. So you would click on the digest scorecard and it would open this tracker on the left-hand side that you can see next to your swallowing image. And then throughout the examination, you would have the opportunity to make selections on the penetration aspiration scale scores for different bolus types. So you can see this here. As well as the residue estimations for different bolus types. And one thing to note is that you don't have to track the maximum over the entire exam. That's what the software is doing in the background for you, is sort of organizing those results and pulling them into the final tab, which is here. That will give you the maximum PAS, the maximum residue, and the safety, efficiency, and overall digest grade. So it sort of automates the calculation, if you will, the crosswalk of that flow sheet for you. I will tell you that it's very important to know digest well if you are going to incompletely make selections on the first tab. Like if you're just putting in the worst, you have to really understand the logic because the results here assume that you've put in selections for all of the boluses that you tested. And And that's just for folks who might like to shortcut, because I've tried to shortcut myself and discovered that you really do have to understand the logic if you're going to shortcut. That means the best way to use the scorecard well is to do the paper version at first and understand the tool on its own and then start using the scorecard. The other component of the scorecard is the opportunity to then generate a custom report using Tim's reporting template. If you've generated the data in the scorecard, it will automatically output your digest into your clinical report, which is an excellent feature for standardized reporting. All right, so that's the scorecard. What about the measurement system? Tim's measurement has really come a long way, and I'm super excited about a lot of the functionality in this space. And I'm going to play this video here, which many have seen from their website or from demonstrations, that demonstrates how the lasso tool in their measurement software can be used to help you calculate residue estimations. So you can see here the residue in the vallecula. The user is pulling over this sort of auto lasso tool, marking that as residue here, and able to see, if I go back to this, I'm going to go back just a minute. You can see that what's missing from this video, sorry, is that the original full bolus was previously segmented. So segmenting meaning drawing a boundary around the edge of its perimeter, or delineating the boundary of that bolus. And the bolus was set to, let's get back here. The full bolus was set to 100. And then when the residue was segmented, the pixels are then used in reference to that as an estimation. And so you can see that this is estimating that this bolus here is about 6%. So the pixels here are about 6% of the total pixels that were in the full bolus previously seen. And if a clinician was sitting there on the fence saying, is this under or over 10%, they might use that to help them feel confident that they're making an accurate estimation of the bolus residue. I would like to briefly acknowledge sort of caution when using these tools to be an informed user, that segmentation-based methods and the visual estimation process that we use in Digest are not the same. And for that reason, they don't always agree. So this is just highlighting work that we've done in collaboration with Katrina Steele's lab. This is under peer review right now, where we took the original training set for Digest and compared residue estimations from that to residue estimations using the segmentation-based approaches like you just saw. And we concluded that the residue measures between these two methods are often concordant when you have small to medium degrees of residue. So those less than 10%, 10 to 49% residue buckets. But when the residue was 50% or higher, there was often pretty significant discordance between those estimations, and a lot of it had to do with pre-existing residue that's already in the pharynx that kind of gunks up the segmentation-based approaches. And so I share this slide here to sort of think about the reason why the segmentation, the visual estimation may not always agree, so that when you're using these tools, you can think about, is this a good scenario where it will work or is it not? So what Digest trains a rater to do when estimating residue is to watch the full swallow. So you're watching the full time series of the data, and you're specifically estimating residue based on 3 factors. So you're looking at what enters the pharynx, what exits the pharynx, and what remains. And you're putting that all together into data to say, okay, what's the total percentage of that bolus that is retained within the pharynx? So I'm going to show you an example here where we've sort of annotated those decision points. So here's the bolus in the mouth. We're waiting till it pushes into the pharynx. This is what entered the pharynx. This is what exits. And this is what remains. And if we watch that again, we can see that all 3 of those time points are pretty clear. So I would be able to draw a boundary around this and this total bolus and say that was my 100%. When I watch it exit, I can say more than half of that total bolus looks like it's going into the UES. And then this is what I would segment as the amount of residue that's retained in the second part of using a segmentation-based approach. In a scenario where I can clearly see the full bolus and the residue, and there wasn't a lot of pre-existing residue, the estimation should work pretty well for segmentation because segmentation relies on two frames. You need to be able to see the total bolus, the what enters, and you need to see what remains clearly. And those two frames need to be very clearly selectable. When those are difficult to identify is when these approaches may not give you a very accurate result. I'd like to move on in our last few minutes or 10 minutes or so to describing how Digest integrates with other tools. As I mentioned at MD Anderson, we have clinically implemented Digest since it was developed in 2016 for all of our modified barium swallow studies in our cancer practice. We published the results of that clinical implementation last year in the Dysphagia Journal. And for those that are interested in understanding our practice protocols surrounding how we train and use Digest, this is a good kind of how we do it. It has a very long and detailed description of our clinical program for dysphagia. One of the important features of that program is that Digest is not the only measurement we use in our standardized swallowing measurement protocols. In our clinical practice, we incorporate multiple standardized outcome measures. For the functional status of the patient, we want to know what they're eating and what we recommend from a diet level. We use the PSSHN for what they're eating. We use the IDSI as a standardized way of reporting our diet recommendations. We also want to know how the patient perceives their swallowing function, and for that we use the MDADI in our swallowing clinics. And more broadly, we use a multi-symptom cancer instrument called the MDASI in other oncology clinics, and it has two swallowing related items. And then Digest specifically serves the purpose for our clinician-graded or imaging-based assessment of the physical swallow. Even in our swallow study, however, Digest is not the only thing that we are standardizing. So in our clinical note templates, we use structured flow sheets to identify anatomical observations. These include specific regions of edema within the head and neck. These include surgical defects, hardware, and stricture. Digest serves as our measure of the swallowing function of the patient, meaning how safely and efficiently they actually clear the bolus. We report the Digest alongside the penetration aspiration scale as well as the residue data. And then finally, and very importantly, we map that to the physiology. So we report the Digest grade alongside the MBS IMP. I'm going to close with describing the way that we use Digest in clinical decision making. And obviously, the sort of caveat is that I work in a cancer care environment, so I'm going to give you cancer examples. But I think about Digest when it comes to the clinical management of the patient as the big picture layer. I use it in my clinical decision making as sort of a risk stratifier, like, does this patient need help? How much help do they need? And then I also use it to think about where we're focusing our dysphagia management efforts. Am I trying to improve the safety of the patient or the efficiency of the patient or both? And this brings up an important point, which is that we do get different data from Digest. So we get the overall grade of the dysphagia. For those that work in cancer, this sort of borrows from cancer staging, where you get the overall stage of a cancer. This is a stage 3 head and neck cancer. That's the Roman numeral, right? The AJCC grade. But we also get, and for Digest, that's grade 1, grade 2, grade 3. But we also, for Digest, get the profile. And this is the sort of key components that underlie that overall stage. So for Digest, that would be, for instance, S2E0 or S1E2. These are both overall moderate digest grades, but the profile on the left reflects a moderate safety impairment with normal swallowing efficiency, whereas the profile on the right reflects mild safety impairment with moderate inefficiency. And you can imagine that when I'm thinking about my clinical management, just looking at these two patients, I know that the patient on the left with a S2E0 profile needs more help to swallow liquids safely, whereas the patient on the right with an S1E2 profile probably needs more help to swallow solid foods more efficiently. And so as a clinician, I find that the clinical value of digest is often less about the overall digest grade in my report. My referring physician may want to know that. My patient may want to know that as like an overall summary, but my management is far more driven by the digest profile. I like to think of it like the digest grade helps me get in the right lane, like how much help does this patient need? And then the profile helps me to identify what specific needs I'm working on. And then finally, my strategy for what I'm doing is going to be based on the physiology of the swallow underlying that impairment profile. So some of the key ways that I use digest in my own clinical practice, one of my favorites is clinical handoff. We work in a really busy practice with more than 20 speech pathologists. And so when I'm like handing off a patient to a clinician on the floor or someone up in the clinic, I can easily say, this was an S3E0 result. And you immediately can kind of envision that that's a swallow where the patient was consistently showing higher penetration aspiration scale scores in the 7 to 8 range, but had reasonably good efficiency. And I know immediately that that's a patient where I need to focus my efforts on managing aspiration of liquids. I also like to use Digest to share results with patients as well as referring providers. I find that patients really find it useful. For instance, this morning I was doing swallow studies and I had a patient with a grade 3 digest result who's suffering from late effects of head and neck radiation, really on the fence about decisions about getting a feeding tube, and was able to say, this is a reasonable question you're having. People with a grade 3 digest result, about 50% of them use a feeding tube and 50% don't. And it sort of puts into perspective where the patient sits relative to their peers. I also like Digest, both within a large team, but also in clinical training to sort of calibrate that the recommendations I'm making or the recommendations I see in the chart of somebody I might be auditing, that they make sense with the severity of the dysphagia. And what I mean by that is there are certain expectations we have. They're not universal. Sometimes they don't make there might be exceptions to the rule, but there are certain expectations about the amount of strategies or the diet recommendation you would have with a given digest grade. So for instance, I would expect a patient with a grade 0 digest would be unlikely to recommend strategies targeting pharyngeal phase swallowing, maybe some oral phase strategies. Whereas a patient with a grade 1 result might have a simple, likely single strategy, a little bit more frequently recommended. As we start to move into grade 2, but for sure 3 and 4, we would expect to see increasing complexity of strategies, sometimes used in multiple combinations. There are also dysphagia or digest profiles where I expect particular types of strategies to match. For instance, a supraglottic swallow would be expected to be used in a patient with safety impairment. So if I saw a supraglottic swallow for a patient with an S0, it would give me pause to reflect on why I'm making that recommendation or why a clinician on my team is making that recommendation for us to all sort of troubleshoot the rationale behind it. Likewise, I would expect that an effortful swallow or a liquid wash would be unlikely in a patient with an E0 digest result. And finally, digest should relate, and specifically the digest profile, the safety and efficiency profile should relate to the diet recommendations we make, where we would expect that as the efficiency grade gets worse, that we move down the pyramid for foods in the IDSI framework. And as the safety grade gets worse, we would expect the recommendations to move up the drink level pyramid for IDSI. Finally, I'll give you an example of how we can use Digest to personalize our care pathways. Again, this is going to be a cancer example, but for many who work in the cancer space, we know that prehab pathways are pretty popular for swallowing preservation in patients going through radiation to the head and neck. And we often will look at the baseline digest grade of an individual to sort of scale up the amount of swallowing therapy a patient might benefit from receiving during their head and neck radiation. So we would have sort of a minimum, what we call our RAD path, our swallow pathway that follows a patient through SLP care during head and neck radiation. And if you had a grade 0 digest result, you'd probably just get the standard, sort of vanilla radiation swallow pathway. If you had a grade 1 result, we would implement earlier swallow strategy training and earlier mealtime planning, knowing that you probably need more help, more personalized help to keep you eating throughout your radiation. If you had a baseline grade 2 result, at this point, we might have you see speech pathologists more frequently during your radiation and might consider targeted device-facilitated exercises and the possibility of a proactive feeding tube. And almost always with a grade 3 baseline dysphagia, we would at least start conversations with our oncology team to really advocate for proactive feeding tubes, not to make the patient NPO, but to give them nutritional support, knowing that their swallowing is likely to deteriorate far faster during their head and neck radiotherapy. So I know that was sort of a whirlwind through 4 of the key components about using Digest. And I think that one of the things that's super important when we talk about these specific practice tools in our environment is to think about the fact that it's less about what specific tool you're using or how you're documenting it. And it's more about how you use the measurement tools to really impact your practice, integrate with each other, and give a better result. And that's ultimately our goal with Digest, is to work well within all of the other stuff that's available to us in our dysphagia care. So with that, I'm gonna, I think, maybe stop sharing my screen so that Brooke can come back on and help us go through some questions from the Q&A.
Awesome. Thanks, Dr. Hutcheson. The chat is going pretty wild with just gratitude and thanks to you for your expertise. We have quite a few questions, so I'll go ahead and dive in. There was a lot of questions about the QR code for the new SLP role at MD Anderson, so I did put that in the chat for everybody, and thanks to those who shared it. And then one other question specifically about the pixel-based measurement in TIMS. Some people asked about how quickly you can use those. I use it in my own practice. It takes less than a few minutes to do. And if you want more information, just send us an email and we can sign you up for free training. So now diving into digest specific questions. The first one is pharyngeal residue. Are we measuring after the first swallow or after independent clearing swallows?
Perfect. First swallow.
Wonderful. And then there's another question similar. This attendee asked, can you please speak to the effects of or how to indicate when residue on a given trial is suspected to be due in part to a prior trial?
That's a great question. And, I probably didn't articulate it super clearly because it gets a little complicated, but that is like the number one reason that the pixel-based measurements can like sort of wildly disagree with the visual estimation in high-grade residue, is the problem of pre-existing residue. And what I would say is when there's pre-existing residue, I pay a lot less attention to, if we go back to that slide where it said what enters, what exits, and what remains, I pay a lot less attention to what remains in the setting of pre-existing residue, and I pay a lot more attention to what went through the UES, because that I can see more clearly from the full series. And this is one of the places when we were doing the pixel-based measurements where it was like, oh my God, these don't always work, because you would have these scenarios where clearly nothing went through the UES, but on the pixel-based measurement, because there was, pre-existing residue and it was all getting mixed together, you would sometimes get these measures that were like 10%. And you're like, no, I know I have 100% residue, nothing cleared through the UES. So you have to use your visual judgment in addition to those measures to make sure that they make sense with what you're seeing on the full swallow, if that makes sense. But yes, I
Definitely.
like them a lot for when you're on the cusp and you can get clear two frames. They're great.
Yeah, I know there's a lot of questions in the chat about using pixel-based measurements. So if people have questions specifically about using measurements with TIMS, like I said, feel free to send us an email and we can get you set up for free training. But I'm going to go through the list of other questions.
Or can I
This,
share something on pixel-based measurements?
yeah.
Those of you that are like, I didn't even know those exist. I didn't know that there's a caret at the bottom of your MVP that is the first step to seeing your pixel-based measurement tools. So I kept saying I don't remember if it was Tyler, I was like, we need an upgraded like MVP software. We don't have the measurements. And he was like, click the caret. So there's a little caret at the bottom right in Tim's. And if you didn't know you have these measurement tools, click that. And then you can play around with them as your first step before you even call Brooke and and ask how to do
Yeah.
it.
And I
So
will say, you heard it here first. We're coming out with some updates. If you were at ASHA, you might have seen them if you came by our booth. But we do have updates coming in Tim, so stay tuned for that. But yes, if you check out our website, we have a ton of tutorial videos on how to do measurements, but you can also always hop on a free call with us to learn how to do it. So this person asked, what guidance do you have for SLPs to ensure reliable and consistent digest scoring across clinicians?
it's a great question. So when we did the short answer is training is available and it's, it's pretty accessible, like price wise, and it's completely virtual so that you can do it on your own time. When I kind of felt like when we first were developing the training that it was like overly complicating a tool that was supposed to be simple. But we have seen that doing the training increases accuracy in using the tool. So I guess there is value to it. Um, uh, and specifically, I think where the value is less about the sort of simple use of the tool. It's a pretty intuitive tool for a pretty straightforward swallow study. And I think that the value in training is understanding what to do when the swallow study is messy. And in our clinical practice, often it is kind of a messy swallow. And so understanding the way that we intended the tool to be used when you have to severely deviate from your bolus protocol because the patient's aspirating like 20% of the bolus volume, or when you have a lot of pre-existing residue, like just getting practice with those scenarios to sort of calibrate. I think that's where the training is particularly useful. The other thing that I think the training is probably useful for is a lot of us are self-taught the penetration aspiration scale. And so it's just a place to get more practice with that if you are self-taught.
The next question is about scoring and documentation. This person said,
Yeah.
how long does the scoring and documentation process take once an individual is familiar with Digest?
Great question. We template our MBSs at 30 minutes. If I have a straightforward MBS, I can do my documentation if I've pre-charted. I can do the MBS and do the digest grading and the MBS IMP and close out the note before the next patient. That said, I developed the tool. I'm very familiar and I've been practicing 20 years. I do think that I don't have data on it, but I do think that the use of digest in an unfamiliar user would probably be 20 to 30 minutes to while you're getting familiar with it. But most of the time I get my digest grade in real time. I see a lot of clinicians I know on the call and I want to be like, Price, do you agree? Um, but most of the time my digest grade, I already know when I'm done with the study, and what I spend my time on is going back and feeling confident in my MBS IMP scoring. I also will like this is actually, oh, delete PHI. This is actually the example of the scoring sheets that we use. And so I will often like circle a particular bolus trial on my scoring sheet and just like, I know that that was the worst trial and I'm going to go back and feel really confident in it and sort of identify what I would call the deciding bolus. And that speeds up the process a lot.
Awesome. We'll take one last question and then I'll answer another question about the pixel-based measurements. And for those that we didn't get to, I know there were some people asking for more information about integration of digest with MBS-INP and Aspect C. I highly recommend checking out a webinar that Dr. Hutcheson did with Dr. Steele and Dr. Martin Harris over on Gap Education with Tim Stockdale. It was phenomenal. But this question says, do you still try to apply digest scoring even if the patient's swallow profile doesn't allow you to implement a full protocol of swallows?
Absolutely. Like 99% of the time, I can get a digest grade from a swallow study where we didn't complete the full bolus protocol because we're pretty good at maintaining the bolus protocol when it's feasible. Um, it can't just be because you were in a hurry. You know what I mean? It needs to be because there was a clinical reason that you truncated. And if so, the digest grade most of the time is feasible and generally is valid.
Wonderful. So kind of wrapping up the pixel-based
Oh,
discussion
can I
and
can I answer one question that I see? I'm
yes,
sorry to interrupt.
yes, feel free
Says,
to.
couldn't you just measure the pre-existing residue and subtract it? Yes, we tried that. Please stay tuned for this paper, but not like we tried every subtraction possible to come up with it, and we just never could get the high grade residue to agree very well.
Yeah, and like I said, when this webinar concludes, Zoom will send out an email automatically. I saw Dr. McCoy asked for a link to pixel-based tutorials. I will include several different links, the link for the ASHA survey for CEUs, the application for the MD Anderson position, the MD or the, excuse me, the digest training, which is phenomenal. And then I will also link to a couple of tutorials on how to do pixel-based measurements in TIMS. I will also direct you to a presentation provided by Dr. Steele and Emily Barrett from the Steele Lab. They provided an awesome webinar walking through how to do pixel-based measurements in TIMS. And full disclosure, if you don't have TIMS, you can still do pixel-based measurements with something called ImageJ. So we're happy to help with any of that here at TIMS. So just wrapping it up, if you want ASHA CEUs for this presentation, please complete the survey within 7 days of the course conclusion. And then Dr. Hutcheson provided us with the slides for today's presentation, which will also be up on our website within 48 hours. And if you'd like a certificate of completion, just send us an email at tims-univ@tims.com. And with that, thank you so much, Dr. Hutcheson, for being with us this afternoon. And thank you all for joining us this afternoon. Have a good evening and happy holidays, everybody.
All right, thanks. Bye.
Bye.